I was also, until recently, the chair of the UK's eating disorder faculty. So I have a sense of eating disorder services around the country. Amongst other things, we set standards for those services around the country to try to make quality standard. But that gives me a fairly critical insight into how eating disorder services operate. And essentially, I think my perspective is very critical of eating disorder units in terms of how they adapt to people who have autism traits. Because the patients are having to fit to the service rather than vice versa. There's an inflexibility in approach. And research, which I'll present now, shows that people with autism overlapping with eating disorders, the diagnosis itself doesn't really fit the mark. We've developed concepts of anorexia nervosa, which not only don't suit people with autism, they also don't suit men very well. They don't suit people from different socioeconomic groups very well, and they also don't suit people from different ethnicities very well. I've recently done research on Ghanaian schoolgirls, finding many Ghanaian schoolgirls with aspects of anorexia, but they're citing religious justifications for self-starvation. So I think our conceptualizations of anorexia nervosa fail many people with disordered eating. And today I'm talking about how they fail people with autism traits. I'm aware of time as well. I've got a quarter of an hour, sort of, rather than going on for an extra quarter of an hour and missing lunch, I think it's important you have lunch, and I ought to say that as an eating disorder specialist. So I'm going to carve a quarter of an hour off my talk, and also more so because I'd really appreciate audience feedback, and I think discussion is really important. Not least because the field of eating disorders and the field of autism haven't communicated enough recently. And I've learnt a huge amount from, for example, the Leeds Autism Service, but I've also in my time learnt a huge amount from Kathy, who's participated in our research and helped me understand simple things like communicating emotion, statements like, how are you feeling today? Or metaphors like keep your eyes peeled, and how that's experienced for someone who is on the spectrum. So in terms of eating disorder, I'm not going to go over what I'm talking about, but I'm very much talking about in eating disorder services anorexia nervosa and bulimia nervosa, so where there is a core distortion of body image. The challenges for eating disorder services across the country are that the expertise isn't at all uniformly distributed, and there's no point having really good treatments developed in centres of excellence, only for them not to be available around the UK. We have sort of pockets of treatments of excellence, we have pockets of academic expertise around the country, but then they get sort of rolled out, and there's a certain sort of, as they become more and more diluted, the effectiveness becomes diminished. So we try to judge treatments, not just in terms of effectiveness, but what I've called FACE principles. The treatments need to be feasible, they need to be acceptable, and they also, sadly, need to be cost-effective. But the cost-effectiveness of eating disorder services has become predominant recently, and a lot of services are being developed simply to cut costs, unfortunately. So one size doesn't fit all when you're treating someone with an eating disorder, and there are certain dominant models that predominate in the academic research, but some therapies are harder to research than others. Cognitive behavioural therapy is a lot easier to manualise and test than other therapies. So the NICE guidelines from 2005 let us use a quiverful of different therapies, all of which were roughly equivalent. And then over the next decade, CBT has emerged in the evidence space, and in the new NICE guidelines, that has become the dominant model. So most people with anorexia nervosa are going to be treated according to that model. But that's simply because it's an easier intervention to study than other interventions. Now, I'm not criticising it, but I am saying that there are limits. And what that means are the patients are having to fit the treatment rather than vice versa. My interest in autism dates back to my interest in what's called SEED, or severe and enduring eating disorder. So 1 in 5 patients with anorexia nervosa develop a chronic and fairly intractable condition. And these are people who get treated in very different ways around the country and around the world. In Italy, you'll end up being treated by palliative care services rather than mental health services. In America, you'll run out of funding from your insurance company. And when people present the efficacy of treatments for eating disorders, because it's a small sliver in the pie chart, and the other people within that pie chart are doing quite well in terms of treatment, they tend to get neglected. So my passion is what we do with the people who have a severe and enduring eating disorder that seems not to respond to treatment. Amongst clinicians, they can be quite frustrating, and clinicians will blame the patient for the lack of response. And the patients are being sort of, their already low self-esteem is being elevated by how they're rejected by services, by how they're discharged, or by how they're being told they're not suitable for treatment anymore. So a decade ago, we ran a very large and quite influential randomized controlled trial on managing severe and enduring eating disorders. And this has been published in The Lancet about 3 or 4 years ago. And in my academic base at St George's, and also in Sydney, the University of Sydney, we carried out interventions on severe and enduring anorexia nervosa. And we found that the treatments were effective if you were looking more at quality of life and less at behavioural change. So the people in that category, if you focused unduly on weight and nutrition and you ignored the other factors, they were tending to do quite badly. Whereas if you took the focus away from that and you looked more on quality of life and social adjustment, you would find that paradoxically the weight would also increase. It was just a simple different shift of paradigm. So there are effective treatments and treatment approaches for people who have severe and enduring eating disorders. It's just you have to take the focus away slightly from weight and more towards the psychological processes. But within that group, we realized that there was a lot of unmet need. We began to look at the neuropsychological profiles of people within that group of severe and enduring anorexia. I was looking at the cognitive processing deficits. I was looking at a modular approach to treatment so that people, according to different characteristics, would be given different forms of psychological therapy. So in that sense, the overlap between autism and anorexia symbolises a broader failure of eating disorder services, that services aren't responsive and we need more tailor-made psychological therapies. Currently, patients are needing to fit the service rather than vice versa. And just to quickly allude to other research that I'm doing, not only on autism, but I'm looking at trauma and anorexia nervosa. I've looked at the very high rates of undiagnosed domestic violence and the degree to which many patients being referred for treatment for anorexia nervosa are also suffering PTSD, a variant of that called complex PTSD. And simply requiring those traumatized individuals to change their behaviors is insufficient. We have to provide them with the psychological therapies to address the trauma first. I also published a book on male eating disorders and how treatments for men with anorexia nervosa aren't really fitting the bill. And then finally, I've alluded to culture and how cultural aspects of eating disorders are failing. So the treatments of anorexia nervosa can be delivered in lots of different settings, and I think this is probably a good slide to go rapidly over, except for the very last point there, which is the evidence is becoming skewed to the treatments that are easiest to evaluate. And I'm part of the problem. I've manualized particular treatment approaches. I've manualized a body image therapy, which has proved quite effective. And by virtue of writing something down and turning it into an object, you can then measure it. You can almost sell it. So it becomes quite sort of sexy. People like it, and you send them a copy of this manual. And some aspects of psychological therapies are easier to manualize than others, but we're in the danger of throwing the baby out with the bathwater. Another metaphor, which, by the way, people in the audience who are on the spectrum may find quite difficult. Therefore, the treatments that are currently being rolled out in terms of anorexia nervosa are very manualised, and they suit the many, but there are a significant minority who they're not suited to. And unfortunately, again, the patients are being required to fit the manual rather than vice versa. And then when the treatment doesn't work, we blame the patient for that. We also have risk issues to contend with. Anorexia nervosa has the highest mortality of any psychiatric condition, higher than any condition other than probably heroin abuse. So we're having to manage a condition where patients are at significant physical risk. But the trouble with risk management is that the physical risk and the psychological risk can be sort of opposed to each other. In simplistic terms, we can force someone onto a medical ward against their will to save their lives in the short term. And in doing that, we can disempower them and make their condition harder to treat in the long term. Now, most doctors don't like psychiatry because it's a confusing and fluffy area that offends their logical perspectives. And most psychiatrists don't like eating disorders because it's even more illogical. I'm also fond of cats. Is Kathy still here, by the way? Yeah. Well, I'm very fond of cats as well. And I think sort of you can't write a rule book on how to get a cat to sit on your knee. Sometimes when people approach people with anorexia nervosa, it's a bit like someone's trying to write a rule book for something which just doesn't operate in that way. You've got to be balancing up all sorts of different conflicting factors. The risk arguments are becoming less influential than the money matters, and money is now talking. There's a drive to shut beds. There's a drive to rationalise and shut services. And this is because the treatment of eating disorders is very costly business. And the money that's being diverted is often being used in a one-size-fits-all manner. And I think that's quite unfortunate, that it's becoming a little bit more about commissioning and a little bit less about what the patient needs. So I began looking at autism quite a while back. I mean, our research team started this work in 2005. So I think we were the first eating disorder research team to think, well, let's scratch our heads, and is there something going on in terms of autism? And since then, we've published quite a lot of research, which is listed there, looking at that overlap. And it's continuing. I have the largest cohort of people who have both autism and anorexia, and I'm following them up over a decade now to see what happens next and to see how their autism traits are influencing their treatment outcomes and their quality of life. And I'd also pay testimony to Jeremy Turk, who's the professor at the Institute of Psychiatry and who's taught me probably more than anyone else in terms of autism. Vanessa Hook was my PhD student who was looking at this area over 5 years, and her PhD has addressed autism and anorexia nervosa. But even before then, Elizabeth Vence, who's in Sweden, was looking with us at the overlap between autism and eating disorders, and she distributed questionnaires addressing autism to patients with eating disorders and finding very, very high rates of apparent overlap. What we couldn't know, though, was whether it was genuine or not. So if you have a chronic illness and you've been in hospital for a very long time, you may then show some traits that are akin to autism. Secondly, if you're malnourished and in a state of physical starvation, that can mimic aspects of autism. So we weren't sure at that stage whether the overlap between an eating disorder and autism was a real overlap, or whether it was firstly because of the impact of institutionalization on patients, and secondly, whether it was an artifact of the nutrition and the impact that has on people's brains. And meanwhile, a team at the Institute of Psychiatry were looking at concepts of what's called central coherence and cognitive style. So they were doing a much more intricate work on the neuropsychological profiles of people with anorexia nervosa, and again coming out with facets that were akin to autism. And Kate Chankuria, who's a psychologist at the Institute, has really been at the forefront of developing, was at the forefront until Will came along. Is Will in the audience? To look at how we might begin to develop psychological therapies to help people where this overlap begins. And cognitive remediation therapy was an approach that Kate has been developing, later developed into something called CREST, which is a variant on that. So we have a systematic review of autism and eating disorders, which was initially dominated by Chris Gilberg, who's a psychiatrist in Sweden. And of the studies that we examined, about 3/4 of them were all by his group. And in fact, they were all the same patients. So he took these people and he just was doing lots and lots of long-term research on them. But he found essentially very high rates of unrecognized autism, 10 times greater than the previous studies. And we know that the treatment of severe and enduring eating disorders is also challenging. So my research hypothesis was, well, if we look at people in that severe and enduring category, are they overrepresented for autism? And might that therefore help us develop more effective treatments? So there are two ways of looking at this. One is under a microscope, where you take a few people and you give them a battery of neuropsychological tests and see what comes out of it. And another way is through a telescope, where you're sort of taking an overview of large populations. Are any of you involved with a charity called Girls Talk? Well, that's a charity that Jeremy Turk is involved in, and it supports girls with autism who are often underdiagnosed and under-supported. And with that group, we're looking at the prevalence of eating disorders amongst those women and girls. So the study was to look at the prevalence of autism in an eating disorder population, and then to see if it linked with the severity and the chronicity of the condition, to then see what effect this would have on the outcome in terms of treatment. I wanted to look at whether there was a specific link between aspects of autism and specific eating disorder presentations. And I wanted to see whether some of this could be explained simply by malnutrition. So my hypothesis was that people with autism would be overrepresented in the group of treatment-resistant individuals who develop a severe and chronic condition, that they would drop out of treatment readily, but that some of them might change in their psychological profiles as they gained weight. And I love doing research which confounds my ideas, where I'm proven wrong. And to cut a long story short, I found that the people entering treatment who had more autistic traits tended to stay in treatment more rather than less. Now, that wasn't what I was expecting, but perhaps if I'd talked to Hannah earlier on, we would have perhaps found that unsurprising, because you have someone entering an environment that's very scheduled and structured, where you're given a clear set of rules and objectives. And so, of course, you absorb that environment and you obey the rules and the structures as long as you're in that environment. The trouble is when you then leave the environment, the changes aren't sustained. And I think that's what Hannah was saying earlier, that when you're an inpatient, it's one thing, and then you're back home and it's another thing. And so that's what my current research is finding, that although the patients with autism and anorexia were adhering to treatment, they were doing what they were told to do, what they were being told to do wasn't necessarily helpful to them, and it didn't necessarily mean that they got better. And there's clearly a challenge in understanding other people's mental states, if you are on the spectrum. You're being asked to talk about emotions and feelings using a language that may not come naturally to you. And my colleagues who work with people with autism, and more so people themselves with autism, would easily understand that. But most eating disorder services don't understand that. Most eating disorder services have very little experience of the world of autism, the world that most people in this room are operating in. So I think there's a real need to cross-pollinate and for eating disorder services to start to listen more and talk less. The concept of anorexia nervosa is as a condition that helps people to function and to survive. It's a functional disorder that it may be maladaptive, but it helps you cope with emotions and emotion regulation. It's a solution to a problem. It's technically called ego-syntonic. It comes out of yourself. It's part of who you are. So getting rid of it isn't going to come naturally, because the act of ridding yourself of the eating disorder makes you feel worse rather than better. And to reach a point in life where you are willing and ready to do that, you have to have firstly been allowed psychological therapies that grasp the existential aspects of your life, that talk to you about where you want to go, what gives your life meaning, rather than simply taking a more mechanistic approach to therapy. And if you lie on the spectrum, it can be harder for you to understand your core emotions and also harder for you to communicate those emotions. There are differences in executive function in people with autism, and I won't go on about this because people in the room are more expert than me about this aspect of things. There are problems with central coherence, of seeing the wood for the trees. But that's all about what's different in people with autism. There are also things that are different in eating disorder services. There are deficits in those services where people are assessed and they're assigned immediately to a behavioural intervention which expects folk to change before they're perhaps ready to change. In order to be ready to change, they need to understand what's going on internally. They need to accept and assimilate the psychological formulation that then helps them know why they should endure this process of change, which is so bloomin' awful. So the research, which I'll skip over to some extent, we looked in the PhD at central coherence, at something called set shifting, so moving from one course of action to another, at social cognition and emotion, and then at personality traits, but particularly obsessive personality traits. We were also looking at associations with anxiety, with depression, and with nutrition. And we were looking primarily at how common was autism in people attending two different eating disorder services. So it was a multi-centre trial. And we were linking it with the eating disorder severity and its chronicity, as well as the eventual treatment outcome and compliance with treatment. I was also looking at the changes in nutrition, at changes in tests of executive function, and I'll skip over this because it's not of general interest, but it's helpful to know what are the particular aspects that are different. So we recruited ultimately 71 people from St George's in London as well as in Yorkshire, hypothesising that the traits of autism would lead to treatment dropout or treatment resistance, and also postulating whether autism was simply an artefact of malnutrition. Been lots of research in the 70s I was involved in before they invented medical ethics, where we starved medical students for weekends and we sort of saw what happened to their behaviours and their thoughts. And some aspects of what seemed to be anorexia nervosa were actually simply because you were in a state of starvation. Rather primitive responses emerge. You become agitated and restless. Your body is telling you to be out there foraging. Your need for sleep diminishes. Sleep architecture alters. Your thinking becomes sort of sticky and rigid. And these are things that, as evolved responses, you would want, if you were God and you were trying to design the human body, you would want the starving person to behave in certain ways that overlap with anorexia. So I wondered if some of the overlap between the apparent autistic traits and anorexia was simply an artifact of that, or were they in fact genuine? So I looked at the autism traits, the diagnosis, the eating disorder and its related behaviours, and an array of neuropsychological tests. And we found that 28% of this sample scored very highly for traits of autism, and 10% would be categorically within the spectrum. So this provided some more robust evidence than these questionnaires that had been used already. And we were using sort of detailed interviews, 3-hour interviews, taking collateral history from parents. We found that 37% of the participants left treatment early, but that the people who had the higher autistic traits were more likely to stay in treatment. So again, it was the opposite of what I was expecting, but it makes a lot of sense looking back. And it's also what Hannah was saying earlier, that you're in an environment where you're given a set of rules, clear objectives, so you hit the ground running and you do exactly what's expected of you. I do like to do research where I'm proven completely wrong. Another claim to fame of, if I can boast of my failures, was about 15 years ago, I proved that people with eating disorders were more likely to have season of birth changes, rather like people with schizophrenia. And some of you in the audience may know that there's a trend towards certain season of births in people with schizophrenia. So I looked at a huge sample of hundreds of thousands of people with eating disorders, and I found, sure enough, there were exactly the same trends. And this spawned an international research interest in season of birth and anorexia. And I'd go to conferences around the world, and there would be groups looking at season of birth. And 3 years ago, I examined the definitive PhD on the subject in Norway, which proved that I was utterly and completely wrong, and that I'd been applying the wrong sort of maths. So as a scientist, we should welcome research where we're proven wrong. And in this case, my expectation that autism would lead to drop out of treatment was completely and utterly wrong. And that's great. It really helps us move forwards in terms of what we're really wanting to do, which is to help people and improve their treatments. Unsurprisingly, we found that autism linked closely with obsessive traits. But whereas those obsessive traits tended to get better as people gained weight, the autism traits didn't. So we can confidently say that there's a genuine overlap between autism spectrum disorder and eating disorders, and it's not simply down to being malnourished or starving. It's a real factor that continues even when people start to regain weight. Aspects of obsessionality change, but aspects of autism don't change. They're not artifacts of malnutrition. So the implications are that autism is common in eating disorders, and therefore autistic traits are likely to influence psychological therapies. The therapies that are standard in eating disorders aren't going to fit the bill. They need to be adapted. And is there anyone in the audience who's involved in delivering psychological therapies for people with autism? Yeah, so at the back, and I think we'll hear more about that. Is that right? Yes. So that's the key thing. I mean, the whole of my research is geared towards that, about what we need to do differently as eating disorder specialists when it comes to adapting psychological therapies. It doesn't have to be radical, but but it's about understanding how therapists communicate emotion and how people with autism understand emotion and how they understand language communication. So contrary to expectations, people with autism didn't drop out of treatment prematurely, but research which I'm almost on the brink of finishing, which is a 10-year follow-up study, no longer 5 years, now 10 years, is showing very high relapse rates. So the subgroup of people who have an eating disorder and autism, although they stay in treatment and they come out the other end, the benefits aren't sustained. And perhaps Kathy's talk earlier gives us an insight into why that might be. In fact, I'm about to go on to tell you how some of the eating disorder treatments are positively toxic and they can make a bad situation worse. So how should treatments be adapted and how should services be adapted? Kate Chancuria is evaluating specific therapies called cognitive remediation therapy and also CREST. And she's developed a model of CREST which is delivered over 8 individual sessions or 5 group sessions. And it's quite formulaic. It's sort of a very set agenda of therapy. But that is also helpful because it means it's an intervention that's feasible, effective, and cost-effective as well as effective. It meets those FACE principles. So it's a sort of, Kate's work using CREST is the sort of intervention that might be used around the country to help eating disorder services adapt how they approach these matters. But I would also advocate a much more individualized case conceptualization. We need, therefore, for the eating disorder services to cross-pollinate more with learning disability services and to learn more from them. We need to remove barriers and build on the gaps. Some of the barriers are about the diagnoses and the fact that the patient is having to fit the diagnosis rather than vice versa. Some of the barriers are to do with patients not immediately accepting treatment and therefore being labelled unmotivated and being discharged, rather than then trying to deal with the motivational barriers and work with them. There's a need for much better treatment, treatment as well maybe, much better training for staff, so that people who are working, clinicians working in eating disorders, are learning a little bit more about autism and how the treatments that they're giving to people with autism may be quite upsetting to those people. There needs to be a therapeutic shift so that rather than leaving our patients feeling that they have somehow failed, we might want to encourage greater compassion and self-acceptance. After all, an eating disorder is a form of self-soothing. And if you leave people feeling like they're a failure and they've not succeeded in treatment, they're even more likely to resort to the behaviour pattern that actually soothes them most. We can encourage teaching new cognitive and behavioural skills. And we can also accept the things in our patients who are on the autism spectrum that aren't going to change, but to try to look at compensatory strategies. That's not just about trying to change the thinking of the individual, but perhaps looking at the environment in which they're operating and the environmental stimuli which are helpful or unhelpful. It's also important to treat and address other comorbid difficulties like depression or anxiety. And Kathy was talking about how much anxiety was an aspect of why her disordered eating was problematic, as well as emphasising sort of unique capabilities and accomplishments. For Kathy, her athleticism and her athletic prowess was something which she took such pride in. And if we look at those things that might motivate you to endure what recovery from anorexia represents, we might be better able to engage patients in that process. But staff need to learn new ways of communicating. They need to adopt a new lexicon, a new way of talking about feelings. There has to be a better understanding that an eating disorder is a solution to a problem and not just a problem in its own right. So once you analyse what is being solved, you can perhaps help someone find alternative solutions. There's also the lived experience of someone with autism who's put into treatment and then exposed to aspects of treatment which are terrifying and can be, frankly, quite traumatizing. And I see people who have never recovered from treatments that they've received for their eating disorder in the 70s, 80s, or even later. Treatments like nasogastric feeding or simply being detained to hospital, it's terrifying for everyone, but it's even more terrifying for someone who has autistic traits. Eating disorder units often have very strict regimes when you're going to wake up, when you're going to eat breakfast, when you're going to attend certain group activities. And people with autism will already have their own internalized strict regimes. So when the two collide, it can be really problematic, and we can't simply expect the patient to fit the unit. The unit has to adapt to the patient. Group work is very difficult in my personal experience of managing people who have autism and anorexia. They can enter a group setting, and group therapies are very much used in eating disorders. But for someone with autism in a group, particularly of people who predominantly aren't on the spectrum, the group can sometimes be quite toxic. The language used can be challenging, and it can really disrupt the emotion regulation. So at the moment in London, I'm trialling in a case series what's called positive behaviour support, which is new in the field of eating disorders and much less new in the field of autism. Is this a concept that people have heard of? So it's really new to me and not at all new to you. So I won't go on about it, but it's a novel approach that we're using at St George's at the moment. Analysing the function of the eating disorder, trying to then address the communication difficulties, looking at how the eating disorder provides an escape perhaps from a living circumstance, an escape perhaps from interpersonal relations, people in the community environment in which the person with autism exists, or an escape from a particular activity. So figuring out what purpose does the eating disorder serve in the individual on the spectrum, and therefore to look at ways of changing eating routines that are positive and constructive, analysing the situations and settings that engender the eating disorder. And what I'm doing isn't getting the person to come to the clinic, but we go to their environment. And the vast majority of eating disorder services, the initial assessment is in the clinic. But I think you can learn a lot more by going to the environment and analysing what's actually going on in the mealtime. And part of that analysis is using a functional behavioural assessment, which again will be very conventional to most of you, but it is quite novel in the world of eating disorders. And I won't linger on this because most of you will be familiar with what functional behavioural assessment is, but it's a very helpful and novel approach in treating people with anorexia. We've also got to look at how our treatments are making things worse. Eating disorder services, the environments can be really noisy. There can be ward-imposed schedules, so patients who are having to fit a particular regime that actually aggravates them to a great extreme. Smoking. 5 years ago, I was put in a position where I had to detain 3 different patients, all inpatients, because they wanted to smoke at a particular hour of day, and that wasn't permissible within the regime of the unit. So they were then seeking to leave because the unit couldn't allow the cigarettes. Now, I'm not at all in favour of smoking. I'm perfectly supportive of Trust's policies in trying to prevent smoking. But I think sort of letting someone have a fag at 10 o'clock as opposed to 11 o'clock is quite a simple thing. And breaking that regime, can be quite upsetting to people. Then you have the group work that the services adopt and how that needs perhaps more flexibility and mindfulness of the autism. And then you have the exposure to other people's behaviours, self-damaging behaviours, the way that other people in a group might respond to emotion. Kathy was talking very openly and honestly about her peer relations when she was a teenager, and then you're put into a unit, often predominantly women, and sometimes the same peer relations can be replicated. You can have dynamics of bullying, you can have people being ostracised, and sure as eggs is eggs, it's often the people who are on the spectrum who are more at risk of being ostracised and bullied on an inpatient unit, and then that can ring harmonics of memory from childhood. So exposure to other people's behaviour can be very upsetting. So just to conclude, autism traits are very, very common in eating disorders, and there's a high prevalence of fully fledged autism spectrum disorder in people who have eating disorders. It's not, as was previously suggested, explained by malnutrition. It's a genuine and substantial finding in a significant minority that may go some way to explain why a subgroup of patients aren't getting better according to conventional treatments. Some aspects are simply down to malnutrition, and obsessive behaviours do tend to improve with weight restoration in an important minority. But there are still lots of people out there who are in eating disorder services who lie on the spectrum, or they have traits, and they haven't, as Kathy had recently, had a diagnosis, and they haven't, as Kathy has had, therefore been able to develop an understanding themselves of what makes them tick. And meanwhile, the eating disorder services themselves can be inflexible, and there are lots of new service changes that are actually a fig leaf for cost savings. So already we have a situation where one size fits all and the patient has to fit the service. But unfortunately, my sense is that that's getting worse, and that people are needing to sort of fit down a narrow category, and then if they don't respond to that, they're being blamed for that and discharged. So we need to modify our approach to people with autism, rather than expecting people with autism to change for the services. We have new psychological therapies, such as cognitive remediation therapy, and new approaches to people, functional behavioural analysis, which seem to be promising, effective and cost-effective. But we also need service philosophies to change. We currently have the largest ever long-term cohort of people with autism and anorexia nervosa, and I'm following them up to see the longer-term outcomes, which are sadly predictable but depressing, in that there are very high relapse rates. And that leaves 5 minutes or slightly more for questions. Thank you.
Are you okay just dealing with questions?
Yeah. Okay, thank you. Yeah. Has anyone got any questions or comments? Yes. Yeah. Well, I think you need to agitate politically. For example, NICE guidelines clearly say that BMI shouldn't be used as the sole criteria for whether someone fits a service or not. And yet it's quite common to say, look, you're not thin enough to be treated. Go away and lose weight. Go away and starve yourself, and then you'll fit the treatment. So I think it's a common story. It's a common narrative. I don't have a solution to it, and I'm relatively pessimistic. But it helps to agitate, and I'm sure you've done that. At the front there. Sorry.
I feel like I'm going to sing with this. John, thank you for a very illuminating presentation. I'm not an ED specialist, I'm not an LD or autism specialist, but I am a clinician who spent 35 years in psychiatry. But I have a question which I don't know whether you'll be able to respond to or not, but do you feel that in inpatient ED services, particularly CAM services, that there's an over-exaggeration on focusing on emerging personality issues rather than looking at whether autistic spectrum is the issue? So in my experience, I'm looking at lots of services around the country who are saying we've got a significant increase in emerging personality disorder, and when I question about ASD assessments, etc., I know it's not to do with that, and I don't know whether we're not looking at that enough.
I think you're absolutely right. And I also mentioned my research on domestic violence and trauma, and I'm finding that there are many people with something called complex PTSD, where they've been repeatedly traumatized, are being diagnosed with personality disorder instead. Now, there's a validity and a helpfulness in a personality disorder diagnosis, as it helps understand treatment, but it can instead be used by the service as a way of dismissing people. So it's like almost a get-out clause that you say, personality disorder, not an eating disorder, we're not going to treat you. So I think you're quite right, yes.
Hi, I'm a psychiatrist in eating disorder as well, and I believe the NICE guideline have said treat ED if it is along with the comorbid UPD, so we are getting there. But I do feel strongly about SEEDS. And I have various questions, and my service is struggling, and we do end up taking, at the end of the road, palliative care approach. But I was just curious about, linked with autism, was there anything that you discovered in your study in terms of outcome, if they have a autism disorder in SEED?
Yeah.
With the neuro
Yes.
changes that
So we definitely found a link between SEED and autism. And we definitely, by definition, people with SEED, severe and enduring eating disorder, by definition, they're not getting better. So it seems a very plausible hypothesis that the autism gets in the way of treatment response. And so firstly, what I'm doing now is seeing if that's true. So I'm assessing the people who had SEED and anorexia 10 years after the original research to see what their lived experience of treatment has been. And secondly, I'm listening and learning as to how the psychological therapies conventionally used for eating disorders could be adapted using the therapy approaches that the many people in the room who treat people with learning disability already know about, but I know less of. So I've learnt a lot from Jeremy Turk in the Institute. And as I was saying earlier, we've got this experiment going on using a behavioural formulation approach. But I think it's really the way ahead is firstly to acknowledge autism, and then secondly to learn from learning disability services, but also the service users more than anything, as to what we're doing wrong and how we can put it right.
Sorry, I'm being very greedy, but two comments. You know, in early intervention in psychosis, they have the autoantibodies. They're saying we should do that at the onset. So that might be an idea. But do you have any manual, like in learning difficulty, they have picture manuals in terms of processing and understanding? So just thought because you are into manualizing things.
It's a really good idea, because I work in the same department as, I don't know if some of you know Sheila Hollins. And she's been very helpful in creating literature that's useful. And I hadn't thought of it until this very second. So if I, in 5 years' time, there's a manual, then you're the person who's helped her. Thank you.
Thank you. It's a shame that services are so patchy around the country. We've moved from North Yorkshire, where it was good, to Suffolk, where the only thing the GP can offer is medication. What do you think the chances are of medication being a help?
Well, there's no evidence base for medication in anorexia. There's some evidence base in bulimia, but the trouble is when you stop the medication, you tend to get relapse. So I think there's definite role for medication, but it's insufficient, and psychological therapies are the mainstay. And it's such a shame that you can't predict exactly what you're going to get where. I mean, you know, Tony has been instrumental in developing and delivering an excellent eating disorder service in Harrogate. And I was sort of, Tony, I was actually looking at some notes you'd made 15 years ago. I was reading an assessment, and it was just so insightful. And I think unfortunately, it often depends on individuals who, you know, are really full of vim and vigour. And that vim and vigour then tends to go when those individuals go.
I was just wondering, do you think that when ARFID becomes a bit more recognised, what Dr. Harris was talking about earlier, that sort of differential diagnosis will have an impact?
Yes, but so either eating disorder services will adapt themselves to develop treatments for ARFID, but what I think is more likely is that they'll use ARFID to exclude people, because the psychological therapies that we are trained in are predominantly around body image and body image interventions. And I've manualised treatments for body image, which are completely useless for ARFID. So I think you're right, and I think it will really help us understand how we've been misdiagnosing people with anorexia who've actually had ARFID all these years. But it won't necessarily then lead to treatments unless there are services out there that are going to develop to treat ARFID.
That's where I'm struggling.
Yeah.
There's one question on the screen. Maybe that needs clarifying for someone.
Oh, right. Well, no, that's just or you're born in spring, summer, winter, or autumn. So I showed very definitely that the people with eating disorders were born in spring, and then it turned out to be a load of baloney. But in the meantime, people had great fun, because folk went to Fiji on the equator to do the same research, and other people went to Australia. So people had fun out of it. But I was really pleased to have spawned this ridiculous research. I think I might need to stop there in the interests
Thank you very much,
of
John.
lunch.
Yeah, that's been really wonderful to hear. Thank you.